Good morning, ladies and gentlemen, chairpersons. My name is Shani Dahan. I am coming from Israel as a student of Professor Schoenfeld, and now I'm an internal medicine resident. So first, I would like to thank my colleagues who are sitting here and Professor Schoenfeld for this kind invitation. It is a great pleasure for me to present here. So I'm going to present today a case report of a cardiac arrest following HPV vaccination in a young female. And this case report will take us to a discussion about post-vaccination autoimmunity. So I have nothing to declare. And as a continuation to the agenda of my previous colleagues, I would like to emphasize that our presentation today has no aim of protesting against vaccines. As physicians, we are aware that we should highly recommend vaccinations to our patients because the obvious benefits of vaccine in most cases outweigh the complications. However, we should remember and pay attention to the possible post-vaccination complications, although they seem to be uncommon, in order to better recognize the situation and the patients who might be prone to it, to give them the best possible care. So we'll start with the history of the vaccines, which dates back to 1798, when Edward Jenner inoculated individuals with fluid from the blisters of the smallpox disease, and thus he created the first vaccine. Thereafter, the use of vaccination spread globally and actually changed the map of world epidemics. However, over the years, worries have been raised regarding vaccine safety. And we know that there are post-vaccination complications, and they are well described in the literature, including Guillain-Barré syndrome, immune thrombocytopenic purpura, vasculitis, the POTS phenomena, which was previously beautifully presented, and others. Post-vaccination autoimmunity in general is mainly acute and transient. The real autoimmune phenomena are not that common, but when post-vaccination autoimmunity does occur, it is usually subacute and occurs quite a long period of time after the vaccine is given, which sometimes leads to difficulties proving this cause and effect relationship. And another issue that requires further research is who are those people who are prone to develop the post-vaccination autoimmune phenomenon and adverse event, and how can we recognize them? These topics, among others of this complex interplay between vaccines and autoimmune disease, will be discussed. So we'll start with our case report. We present a 20-year-old female who developed new onset ECG changes and cardiac abnormalities discovered on a routine primary care visit. This patient was a young healthy female, and she had no significant past medical history, apart from hypothyroidism, which is, of course, an autoimmune disease, and receiving the first dose of the HPV vaccine, the Gardasil, 3 weeks prior. A family history of heart disorders or sudden cardiac death was negative. So, during the visit of this patient to her new adult primary caregiver, a baseline physical examination revealed irregular heart rhythm, and therefore an ECG was performed, and as you can see, it showed frequent premature ventricular beats in the pattern of bigamy. And another abnormal ECG was conducted a week later in a follow-up visit, which demonstrated the same premature aberrant conduction with marked ST abnormalities. So, the patient continued with her regular regimen of vaccination. She received her second and third dose of the Gardasil vaccine, and a week following the third vaccination, she started to experience several symptoms, including dizziness, joint pain, which was diffuse, and unusual fatigue. Less than 3 weeks later, she was unfortunately found dead from a cardiac arrest during her night sleep. A full autopsy was performed, but couldn't find any clues or findings, neither anatomical or genetic, that might have been linked to a potential cause of death. So, given the fact that the girl was found dead during her night sleep, we shall review first some of the details regarding nocturnal cardiac arrhythmias. So we know that cardiac arrhythmias are less common in infants and children, and the symptoms presented are often vague and nonspecific. Studies have shown that during the night sleep, especially during REM sleep, autonomic instability and in particular changes in the cardiac sympathetic and parasympathetic tone increase the risk of sleep-related ventricular tachycardia and sudden cardiac death. So, as an example, one of the syndromes known to be associated with nocturnal high-risk arrhythmias is the Brugada syndrome and the Brugada-related syndromes. And this paper described 12 Brugada patients with a circadian pattern of heart rate variability. They actually presented impaired autonomic function during the night, which could predispose, of course, to ventricular fibrillation and cardiac death. And we can see here the result showing that ventricular fibrillation was observed more frequently in the night, than in the day in these 12 patients. So it is obvious from this quoted research that several arrhythmogenic disorders are associated with a higher risk of nocturnal cardiac arrhythmia and cardiac death. Given that our patient died unexpectedly during her sleep and that cardiac abnormalities were indeed detected twice prior to her death, it is possible that she suffered from one of these arrhythmogenic nocturnal disorders. The question remains whether the HPV vaccine administered to her only 3 weeks prior to her death could have triggered such cardiac abnormality and subsequently lead to the sudden cardiac death. So let's review some basic facts about the HPV vaccine, which were already presented. We know that HPV 16 and HPV 18 are responsible for about 70% of cervical cancers, and HPV 6 and 11 are a common cause of cervical genital warts. And on 2006, the FDA licensed the quadrivalent human papillomavirus recombinant vaccine, the Gardasil, which was found to be effective in preventing these cancerous lesions. But what about side effects? So in the first large analysis of adverse event using the VAERAS, the Vaccine-Associated Adverse Event Reporting System, SLADE found almost 32 death cases among 12,400 HPV-related vaccine adverse events reports during the period of 2006 through 2008. Medical records of these patients who died confirmed that there was at least 6 cardiac-related deaths. And the median time from the last HPV vaccination to the time of death was 14.5 days, a time frame which was consistent with our case in which the death of the young lady occurred less than 3 weeks following the third HPV vaccine administration. So following this phenomenal case, we have conducted a further search in the VAERAS database from 2006 till 2017 in order to evaluate the current number of the death cases which are related to the HPV vaccination. And we were very surprised to find out almost 300 cases. Out of them, 2 cases were of sudden cardiac death and 11 of sudden death. So this leads us to a short discussion about how vaccine safety is evaluated. And for those of you who are not familiar with the VAERAS, it is the Vaccine Adverse Event Reporting System used in Europe and in the United States. And we should remember that an increase in the reports to the VAERAS may be due to an increase in several factors. It may be due to a better reporting system. It may be due to a better vaccine coverage. It may be due to an increase in the in the rate of the illness itself, and it may be due to increased risk associated with the vaccine. Only the last one, of course, constitutes a true positive signal for us of a problem with the vaccine safety. And as physicians, we need to be able to distinguish between these factors, which highlights the difficulty of relying on a passive surveillance database such as the virus alone in order to identify true issues of concerns regarding vaccine safety. And one important way to minimize vaccine injuries for us is to improve our understanding of vaccine safety, and thereby we can foster the development and the use of safer vaccine, and also help prevent the loss of public confidence in immunization programs. In order to better understand vaccine safety, I would like to shortly address several aspects of post-vaccination autoimmunity. The first is vaccines that are known to cause autoimmunity in the literature. So, numerous case studies and case reports have documented the appearance of adverse events following vaccinations, and when trying to establish such a cause and effect relationship, one should consider the temporal relationship between the two events, the defined criteria, if there are, and the biological plausibility of such a link. And in fact, a cause and effect relationship like this is recognized for some of the vaccine by the medical community. And the most familiar or famous example is Guillain-Barré syndrome, which is an immune-mediated response that results in direct destruction of either the myelin sheath surrounding the peripheral nerve or the axon itself. And we are well aware of that Guillain-Barré syndrome may follow triggering events, including vaccinations. And this cause and effect relationship between Guillain-Barré syndrome and vaccines was first noted back in 1976 following administration of the flu swine vaccine. And the further rise was noted in the beginning of the 90s. And as we can see here, there was an increase in the number of reports to the virus system following the influenza vaccinations. Another important autoimmune disease which is known to be induced by vaccines and was again beautifully presented just before me is the POTS, Postural Orthostatic Tachycardia syndrome. We know that this form of orthostatic intolerance occurs in younger adults and children, and the hallmark of this disorder is an exaggerated heart rate increase in response to postural changes. In terms of the etiology of POTS, it is largely unelucidated, but an autoimmune mechanism has been suggested due to frequent finding of autoantibodies in these patients, as for example autoantibodies against acetylcholine receptor. But as well, a large study from the Mayo Clinic found autoantibodies directed against cardiac proteins, including the beta-adrenergic receptors. With reference to vaccination-induced POTS, we performed analysis of the virus database, which demonstrate that the HPV vaccine had the highest rates of POTS-related complaint or chronic fatigue syndrome fibromyalgia-related complaints compared to the two other famous vaccine administered routinely in the United States. And in this figure, we can see that although the majority of POTS complaints were reported in up to 15% of the reports, POTS was reported only in 0.07%, thus raising the concern that POTS may be underdiagnosed and simply misdiagnosed, which leads to underreporting of this disease and the incidence of POTS following vaccinations. This leads us to discussion what are the possible mechanisms responsible for these post-vaccination autoimmune phenomena. And we know that vaccines are constructed from several components, including adjuvants, preservatives, and antigens from the infectious agents. Each component of the vaccine might induce an autoimmune reaction or an immune response that can aggravate autoimmunity. For example, adjuvant, which was presented by my colleague Dr. Watad, means to help. It is derived from a Latin word. And we know that the mechanism of adjuvancy are, again, not clearly elucidated, but we know that an immunological adjuvant is a substance that enhances the antigen-specific immune response, preferably without triggering one of its own. And if we continue, with the vaccine components, we know that antigen from the infectious agents are one of the most common causes for induction of autoimmunity in general. So vaccines that contains these antigens from the infectious agents might induce autoimmunity by the same exact mechanism, including molecular mimicry and bystander activation, epitope spreading, and polyclonal activation. So coming back to our case, which raises the question, what were the plausible mechanisms here that may lead to cardiac death following administration of the HPV vaccine? The first one is related to the ability of the HPV DNA in the bloodstream of the individual to induce secretion of several cytokines. So this case report relates to a previously healthy 18-year-old girl who suffered a sudden unexpected death during sleep as well, 6 weeks after the administration of the Gardasil vaccine. And interestingly, they performed a post-mortem analysis, and in the blood and the spleen tissue of this young lady, there were found the presence of HPV 16 L1 gene DNA, as you can see here, and they were identical in the sequence to the HPV vaccine vials. So what is the potential consequence of the presence of HPV DNA in the blood or in the spleen tissue of these individuals? We know that it has already been shown that under certain circumstances and conditions, the non-replicating HPV DNA can activate the immune system. And one example is the TNFa pathway, which microbial DNA fragment can, inside the macrophages, can induce release of this cytokine. And studies have recognized that TNF-alpha is a myocardial depressant, which leads us to the connection to the cardiac death. And in this figure, we can see that when exposing cardiac myocytes to TNF-alpha, the contractile ability of them and the cyclic AMP response is reduced. Another example of TNF-alpha as a marker of sudden cardiac death can be retrieved from this picture, which is taken from a case report of a 20-year-old lupus patient who suffered sudden cardiac failure and death. And when they stained with immunohistochemical examinations of his heart specimen, it revealed a strong positive reaction for antibodies against TNF-alpha. So the next mechanism which may explain the cardiac death following the HPV vaccine is molecular mimicry. And namely in exploring the primary sequence of the HPV L1 protein for peptide sharing with human proteins, Kanduk found 34 pentamers from the HPV viral capsid, which are shared with human proteins. And here we can see only 3 examples of peptide sequences which encode for human proteins. And these human proteins, when altered, have been linked to arrhythmias, to the Brugada syndrome, to cardiovascular diseases, and cardiomyopathy. In particular, 9 out of these 34 viral pentamer are presented in the human protein titin, alteration of which have been linked to cardiac failure and sudden cardiac death. This data confirms and extends previous reports describing a high level of perfect peptide matching between the HPV antigens and the human proteome. And this consequently suggests that there is a possible immune cross-reaction which may represent a risk for cardiovascular abnormalities and fatalities. Molecular mimicry and subsequent causal activity are well-described mechanisms that can trigger autoimmunity, and we should remember that vaccines are designed to hyperstimulate the immune system, and thus they may carry a much higher risk of autoimmunity than natural infections do.
Could you conclude, please?
Yes, sorry, so
Time
I'll
is
go
over.
to the conclusion. We can summarize that the development of vaccines has proven to be successful and cost-effective, and they represent an essential part of our preventive modern medicine. It is obvious that vaccines are administered to millions of people, and not everyone develops cardiac death or serious adverse event, and thus it clearly there are some prior susceptibilities, including genetic ones, and a family history of autoimmunity, which may render our patient to be more prone to develop and respond adversely to vaccinations. And I will skip that, and I would like to thank my teacher, Professor Schoenfeld. And I don't have yet children of my own, so I brought the picture of his granddaughter, and as you can see, she surely is vaccinated to all the regular vaccines. Thank you.
The paper is open for discussion.
All the questions have been asked.
I have a question. Do you make some parallel between postural orthostatic tachycardia and cardiac death?
So, thank you for your question. I was also wondering, because POTS syndrome is well described as a post-vaccination phenomenon. I believe that following POTS, there is a possibility that due to fainting, someone will maybe develop serious adverse event, including death, but I don't know any mechanistic connection between the orthostatic intolerance itself and the direct cardiac death.
Please.
That was an excellent talk. Thank you.
Thank you.
My name is Lila Rosenthal. I'm a family physician in the United States. I personally give these vaccines to people of all ages. A couple years ago, my malpractice carrier, interestingly, sent a correspondence asking that when you give Gardasil for the first time, you keep the patients observed for at least 20 minutes because of increased risk of syncope. So as I'm listening to your talk, I'm thinking to myself, I wonder if there's a relationship between immediate post-vaccination syncopal events or pre-syncopal events and subsequent development of dysautonomia or, heaven forbid, these horrific, dramatic cases of death. And I wonder if you know anything about that, and I don't know what the pathophys would be, but I think it's interesting because I've never before, even though what I'm reading from the CDC right now says HPV, Menacra, and Tdap all are known to have higher rates of post-vaccine, syncopal events. Clearly something is unique with HPV if my malpractice carrier is telling me specifically after the first dose, keep these people under observation. Thank you.
Thank you for this important question. So as my colleague, Dr. Watad says, we did find in our registry of the Asia syndrome that local reaction, if they are massive, for example, at the site of vaccination, can be linked to further adverse events. Regarding the 20 minutes post-syncopal event, in my knowledge, there are no certain recommendations for that, but I always love to keep under observation if I have the chance, so I believe that will be wise to do.
Any additional question? No? Okay, thank you. It's time to close the session.